Good morning, everyone, and welcome to this new session of the conference, Rethinking Everything, COVID-19 in the Americas. On behalf of the organizing committee and the partner institutions that make possible this conference, we are delighted to have you here today. This event is supported by the AHF Global Public Health Institute and the Institute for Advanced Studies of the Americas, both based at the University of Miami, by AHF, the AIDS Healthcare Foundation, and the International Association of Providers of AIDS Care, IAPAC. We are pleased to greet all people who are joining us through BFIRS, the official conference platform, as well as Facebook Live broadcast from AHF Jamaica account. We remind you that you can send us your questions both in the Facebook chat and through the official platform of the conference to address them with our panelists at the end of the session. It has been more than a year since the first confirmed case of coronavirus was detected in our region. Since then, our lives have taken a 180-degree turn, bringing with it great challenges, but also great lessons. Today, our new norm doesn't look as our prior normality. We're gathered to speak about some of the challenges brought by the pandemic, such as our new workspace, vaccine availability, and the need for a new global health convention to ensure equitable distribution and access to medicines, vaccines, and information. We also remind you that the recording of this session will be available in the official website of our partner IAPAC in the conference section in the following website, www.iapac.org. Today's panel is titled COVID-19 and the New World of Work, Time to Rethink the Global Public Health Order. Now, I will introduce our co-chairs, Dr. Kevin Harvey and Dr. Mark Edwards. Dr. Kevin Harvey is currently the Caribbean Regional Director of the AIDS Healthcare Foundation. He has enjoyed a distinguished academic and leadership career in medicine, public health, and infectious diseases. He graduated from the University of the West Indies with an MBBS and MPH degrees, and furthered his postgraduate training with international degrees in the world's leading institution, the London School of Tropical Medicine and Hygiene, obtaining the Diploma in Infectious Diseases, a Master in Science in the Control of Infectious Diseases, and the Hubert Humphrey Fellowship in Global Health and Control of HIV at the Rollins School of Public Health at Emory University. He later achieved the Doctor of Public Health from the University of West Indies. Simultaneously, he obtained certification in managing people from the American Management Association. Dr. Harvey has held several prominent positions throughout his career, ascending the ranks of leadership in administration, public health, control of infectious diseases, locally and regionally. His career started at the Kingston Region Hospitals, then as District Medical Officer, and later joined the Ministry of Health and held positions of Director for Treatment Care and Support, Director of the National HIV Response, Chief Medical Officer, and Permanent Secretary. He later joined the AIDS Healthcare Foundation as Caribbean's Regional Director. Dr. Harvey has published several journal articles and has designed and implemented various programs both within the government and non-governmental sector. He was previously an associate lecturer at the University of West Indies and has also taught courses in public health at the master's level at the University of Technology. Dr. Harvey is also a Justice of the Peace for the Parish of Kingston. Welcome, Dr. Harvey. Dr. Mark Edwards is currently the Dean for the Joint Colleges of Medicine, Veterinary Medicine, Oral Health, and Public Health at the University of Technology in Jamaica. He earned his Doctor of Dental Medicine degree from the Farley Dickinson University at New Jersey in the United States, and has had a distinguished career doing several tertiary education programs. Since 1994, he has held the position of General Coordinator for Jamaica, St. Vincent and the Grenadines, Grenada, Vecchia, Carriacou, and Petit Martinique for the Organization for International Development. Currently, Dr. Edwards is involved in the National COVID-19 Initiative in conjunction with the Ministry of Health and Wellness and the Government of Jamaica. Dr. Edwards, it is such a pleasure to have you here with us today. Well, now I will leave the floor to the co-chairs. Dr. Harvey, please, the floor is yours. Thank you very much.
Very excited to have this panel this afternoon. We have a distinguished lineup of speakers, and we're pleased to be sharing the stage between the University of the West Indies, Mona campus in Jamaica, and the University of Technology, Jamaica as well. So we have two speakers from the University of the West Indies and two from the University of Technology, where we're going to now explore some of the challenges brought on us by the COVID pandemic. And as you may have heard, in Jamaica in particular, we are now having a major surge. So we're going to investigate the vaccines and what they are, what is on the market, what is available. From Professor Christie, we're going to look at the new strains which are leading to new surges in the pandemic after 1 year. And we're also going to look at the current impact on the world of work by Dr. Bailey. And finally, we will look at the global public health order that seemed to have not helped us to really manage the epidemic in a meaningful way. And we're going to look at rethinking the public health order. But I'll hand over to Dean Edwards, who will start the introduction of our first speaker.
Good morning, colleagues. And the pleasure is mine to introduce Professor Celia Christie, Professor of Pediatrics and Infectious Diseases, Consultant Pediatrician, University of the West Indies Hospital, West Indies. She received her MBBS and her DM in Pediatrics at UWI. Then she completed her postdoctoral fellowships in Pediatric Infectious Diseases and Epidemiology, including hospital and molecular, from Yale University in Connecticut. And then she went to the Buckeye State in Cincinnati, University of Cincinnati, Children's Hospital, for 9 years, where she was also a hospital epidemiologist, attending pediatrician, and infectious disease specialist. She returned to Jamaica and, of course, blazed the trail with her control knowledge, where she got into research, lots of infectious diseases, the New England Journal of Medicine, infant mortality, and also HIV transmission from mother to child. She's currently the co-leader from mother to child transmission with the European Commission funded Zika Action International Research Consortium, right, involved in Zika, chikungunya, and dengue. She's also naturally involved in the COVID-19 response, lectures, local, regional, and international. Professor Christie has also received several other international, regional, and local awards for her research, with over 250 published manuscripts and abstracts. She was, of course, conferred the Order of Distinction, a national honor in Jamaica by our Governor General in 2018. She has also received several honors from the UWI Vice Chancellor for her research and her continued contribution to nation building. It is my distinct pleasure to introduce and to present Professor Celia Christie. Thank you.
Good afternoon. It is my distinct privilege, my honor, and my pleasure to speak to you this afternoon about COVID-19 in the Caribbean and the development and the availability of vaccines. Next slide, please. Slide. And so COVID-19 has indeed created its toll around the world in the last year. So globally, we have now over 116 million cases, over 2.58 million deaths, with a case fatality rate in general of about 2%. Community spread has been evident in many countries, with several countries having their second, third, fourth, and even fifth waves. Mutations with variant strains are evident, with increased transmission and virulence. And globally, we have over 350 million doses of vaccines administered. However, these vaccines are being rolled out mainly in high-income countries, and this is associated with a 40 to 50% decline in cases, a 30% decline in deaths, and hospitals are being emptied of persons who are in the older age groups and those with comorbidities. Slide, please. Slide. And so in the United States, Cases have plummeted such that you have a 73% precipitous decline, and there's over 60% decline in hospitalizations and over 24% decline in deaths. This has correlated to over 90 million doses of vaccines that have been administered, and some 10% of the population has been immunized, and so they hope to achieve their herd immunity targets by July this year. And this has happened despite the fact that they've had increased variant strains reported from the UK, the South Africa, and also Brazil. And new guidelines were developed for the fully vaccinated as of yesterday. Slide, please. Slide. And so here in the Caribbean, as you can see from the graph here, we have also had our fair share of this epidemic, where we're now going through maybe the fifth spike, the fifth surge, having opened and closed our borders and put in many different measures to control our epidemic. In general, we have had over 500,000 cases and almost 8,000 deaths, with an overall case fatality rate approaching 1 to 2%. Slide, please. And so the Caribbean is really very much dependent on tourism, and the tourism dependency index is shown here for several Caribbean islands. It ranges from about 85% in Aruba to about 60% in the Bahamas, 40% in Jamaica and Barbados. And the epidemic has really caused a shock to the tourist industry and to our Caribbean economies. Several of our islands have experienced over 70% drop in overnight visitors, especially the Bahamas, Barbados, Belize, Cayman, Dominica, and Grenada. Slide, please. Slide, please. Slide. And so the former slide would have shown that we are very, very at risk for comorbidities, and the rates are very, very high. So the most recent epidemic that we've been having, most recent surge, has been related to social gatherings and quarantine violations and COVID fatigue, such that in Jamaica, our population of 2.8 million, we have near 27,000 cases, with these have increased by a measure of over 16-fold from the end of last year until now. We had over 878 cases a day before yesterday, a 39% test positivity rate. Hospitals are at capacity, and we have over 450 deaths with a case fatality rate of 1.7%. The UK variant strains is here in Jamaica, and the country is now working up 46 workplace clusters. We're now in the danger zone. Cuba has a population of about 11 million, and since January, their cases have also increased fourfold, and their deaths have doubled. They share their healthcare workers with the Caribbean, and their population is to be immunized by the second quarter using their own vaccines. Barbados, their cases have increased eightfold, and however, they are using vaccines and with about 30% of the population immunized. St. Lucia and St. Vincent and the Grenadines, their cases have also increased, and they have also began to roll out vaccines. Slide, please. And so with the most recent outbreak, or the most recent surge, we have been paying a lot of attention to entry requirements into the Caribbean and how we travel around the Caribbean. We're implementing lockdowns, curfews, reduced flights. We're closing our beaches and entertainment centers, and we're increasing our quarantine restrictions. We have variable entry requirements throughout the Caribbean. However, most require travel authorizations after health risk assessments and a negative PCR test within 3 to 7 days to travel in the Caribbean and between Caribbean islands. Quarantine is also being implemented in most countries, whether in home or in hotel or state-based quarantine centers. We recognize, however, that as tourism rebounds and as vaccination rates increase in our visitors, for example, in the United States, our visitors will want to come to the Caribbean destinations, which have low risk for SARS-CoV-2 and transmission with high immunization rates. There is a call now for digital vaccine passports, but this is very controversial, as you can well imagine, and lots of ethical concerns are being raised, as you can see here. The WHO at this point disagrees with this point because they feel that the efficacy of the vaccines in preventing transmission is not yet clear, and the global vaccine supply is far from reaching everyone around the world. Slide, please. Slide, please. And so we're going to go through 4 of the vaccines that are being used in the Caribbean. Before that, the Pfizer-BioNTech vaccine is being rolled out in the Caribbean. There are several countries that have gotten this vaccine, and several Caribbean countries are also interested in receiving it. Vaccine efficacy so far is 95%, 7 days after the second dose, when tested in over 36,000 subjects. There were just 8 cases in the vaccinees and 162 in placebo recipients. Vaccine efficacy was high by age, sex, race, ethnicity, and comorbidities, and consistent with the general population. Slide. The Moderna vaccine is also regulatory approved in several countries around the world and also in several Caribbean countries. This vaccine has a vaccine efficacy of 94%, as shown, with just 11 cases in the vaccine group and 185 cases in the placebo group. Slide, please. Reactogenicity in post-marketing surveillance for these both mRNA vaccines has been shown for over 13.8 million vaccine doses administered. You can see here that there were almost 7,000 cases of adverse events reported to the VAERS system. 91% of these were classified as non-serious, and of the 113 deaths, 2/3 of these were deaths in residents of long-term care facilities, and it was thought that they were not unexpected, nor were they causally related to the vaccine. The 35 deaths that were explored in those persons who were not in long-term care facilities, it was thought that the death was due to comorbidities or frail health. Slide, please. And so looking at anaphylaxis in these 2 vaccines as well, for the first 17 million doses that were administered, there were 47 cases with Pfizer and 19 cases for Moderna. It is shown here that the women were most at risk. Symptom onset occurred in more than 76% of cases. Over 77% of cases had a past medical history of allergies or allergic reactions, and over 34% or 26% of cases had prior anaphylaxis. The anaphylaxis rate for the Pfizer vaccine was 4.7 per million doses administered, and 2.5 cases per million doses administered for the Moderna product. Slide, please. And for the AstraZeneca vaccine, this is the one that we really, really want to spend a lot of time on. And this one has had regulatory approval in 68 countries, including in the Caribbean. It's been a gift to the Caribbean from the Serum Institute of India as the Covishield product. It's being rolled out now as COVAX in 14 Caribbean territories, and I'll name them here, those that have received in the last few days or so: Anguilla, British Virgin Islands, Guyana, the OECS, Barbados, Bahamas, Guyana, Trinidad and Tobago, Suriname, and Jamaica got theirs yesterday. Slide, please. Slide. I must speak to the immunogenicity of this vaccine because essentially we're speaking about whether or not it's immunogenic in the elderly. And the data that we have here for the standard dose and the low dose by age shows that it is immunogenic in all 3 age groups that were shown, that were explored. Here we see the SARS neutralizing antibody titers going up, and also the interferon gamma ELISpot by T cells. Slide, please. And here we have the efficacy in over 11,000 participants in the study that was done in the UK and Brazil, and there were they were diverse by race, ethnicity, and comorbidities. So in those who got the 2 standard doses, vaccine efficacy was 62%. In those who received the low dose followed by the standard dose, efficacy was 90%, with an overall efficacy for both groups of 70%. Slide, please. Slide, please. And here we say, I need to go back to that slide. It's important. Go backwards. Okay, so the summary is shown, but in addition, another study showed that vaccine efficacy was 76% against asymptomatic COVID after one standard dose of the vaccine for up to 3 months after the first vaccination. Vaccine efficacy was now higher at 81% up to 12 weeks after the first dose, with a lower vaccination efficacy of 55% for those who had the shorter interval of less than 6 weeks. In addition, greater immune protection was associated with a stronger immune response, with binding antibody responses more than twofold higher in those who had the longer duration between the first and second dose. Slide, please. Slide. And then with post-marketing surveillance of over 8.4 million doses of the Oxford AstraZeneca product, we've had over 42,000 adverse events reported for 3 to 5 yellow card reports per 1,000 doses of vaccine. And what we expected is the common ones that were related to pain and so on at the injection site, and reactogenicity that were related to systemic features. The majority of the adverse events were mild to moderate in severity, and they resolved in a few days. And adverse events after this second dose were milder and reported less frequently than the first dose. And these were milder and in the older age group. Slide, please. So the WHO and the regional PAHO and regional countries have accepted the recommendations for the AstraZeneca vaccine for the Caribbean, and essentially it will be given to persons older than 18 years of age, including those who are 65 years and older, based on the phase 2 immunogenicity data that I showed you, and also the fact that it is found to be efficacious in post-marketing surveillance in countries where this has been used. It's being used in 2 doses, given at 4 to 12 weeks apart, and persons who have had COVID-19 in the past should probably not have it until 6 weeks has passed. Countries are prioritizing their groups at highest risk for immunization. Pregnant and lactating women may receive the vaccine with their physician's advice. Even the variant strains, the UK variant and the South African variant, are circulating in countries. The WHO feels that there is no reason not to vaccinate these in country. And we are to follow up robustly on the use of the vaccine in containing the epidemic. And we know how the vaccine is administered. Slide, please. The Janssen vaccine, I should mention, this one just got FDA approval, and essentially it is being rolled out in 4 countries, and including St. Vincent and the Grenadines. This is an adenovirus vectored vaccine. Efficacy was established in over 40,000 subjects from the United States, Brazil, South Africa, and Latin America. It's given as a single IM injection, and vaccine efficacy is 70%, 14 days after a single dose. Slide, please. And then I should mention the Gamaleya Sputnik GamCovid vac, because this vaccine, not only is it approved in 44 countries with millions of doses administered, not only in Russia, but in other places, but Belize, Guyana, and St. Vincent and the Grenadines are very much interested in this product. This product has a vaccine efficacy of 92%. It was safe, and 94% of the adverse events were mild, and none of the serious adverse events that occurred were thought to be related to the vaccine. It was also very immunogenic. Slide, please. Slide. So PAHO has put together 8 guidelines for using vaccines, and they're summarized here: planning and coordination, resources and funding, vaccine regulations, prioritization, service delivery, training and supervision, monitoring and evaluation, the vaccine cold chain and logistics, safety and surveillance, and then demand generation and communication. And we are implementing this across the Caribbean. Slide, please. Slide. And we are using COVAX in particular. And the COVAX distribution to the Caribbean should be anywhere from 2 to 3% of the population, except for the smaller countries where they're going with 16 to 20% of the population coverage. And we're getting vaccines here through COVAX, through purchases, through gifts, and a whole list of Caribbean countries are listed there in red for your perusal. And we're paying attention not only to the AstraZeneca vaccine, but the Pfizer, Moderna, and Janssen vaccines are eligible for review hereby CARPHA's regulatory system, which oversees vaccine approvals for the Caribbean. I must say that the Caribbean is a world leader in the elimination of vaccine-preventable diseases, with last cases of locally transmitted vaccine-preventable diseases shown here for neonatal tetanus, rubella, congenital rubella syndrome, diphtheria, measles, and polio. Slide, please. Vaccine principles that are being used, which are adopted from WHO SAGE, are the human respect for human well-being, equal respect, national equity, legitimacy, and reciprocity. Slide. Slide, please. And here in Jamaica, just to give you a rough idea of the various vaccines that are being rolled out, I showed you we're getting four different tranches of vaccines are being rolled out over like a 3-month period. And these are the vulnerable groups for phase 1, and those groups that are essential for economic activity for phase 2, and the general public for phase 3, with about 65% of the population to be vaccinated by March 2022 in a year. Slide, please. And this is the system in which they are using here in Jamaica. We have an appointment system. The public makes appointments. They apply for an appointment. This information is fed through call centers, the parish department, the websites, and walk-ins. And then they are placed with regards to prioritize whether they should be put in phase 1, phase 2, or phase 3 based on comorbidities and so on. And then a schedule is set up 3 days before, and the appointment is notified, and then the patient gets the vaccine, and then they are scheduled for their second dose. Slide, please. Vaccination centers have 5 main activities: registration, counseling, vaccine administration, observation, and documentation, as shown here with a time and motion study, minutes varying from 35 minutes to 52 minutes. Slide, please. Implementation levels are shown here as you break it down to the 14 parishes and the various vaccination centers, vaccination sites, and vaccination days, as it relates to level 1, which operates 3 days per week. Level 2 operates 5 days per week. And then we have large blitz sites, which would put out, like, for example, 1,000 vaccines per day, for example, the National Stadium or conference centers or so on. Slide, please. And so for overall implementation, this is shown here. So between March to June would be phase 1, between May to October would be phase 2 rollout, and phase 3 would be between August this year through March next year, when we believe that over 65% of the population would be by then immunized. Slide, please.
Prof, you have 1 minute.
So in conclusion, several COVID-19 vaccines have received regulatory emergency use authorization based on their safety, immunogenicity, and efficacy of 70 to 95%. The COVID-19 epidemic is waning globally, but this is happening in temporal association with the rollout of COVID-19 vaccines in high-income countries since late 2020. This is associated with plummeting cases, hospitalizations, and deaths, primarily in places like Israel, China, United States, and the UK. And after excellent initial control of the epidemic in the Caribbean, we are now unfortunately experiencing increased cases, hospitalization, and deaths, and some 40% of Caribbean countries now have a community outbreak, and this is very concerning. Notwithstanding, since March, vaccines are now being rolled out in the Caribbean through gifts, through the COVAX facility, through purchases, starting with our priority groups of healthcare workers and the most vulnerable. Meanwhile, we know that we have to continue our prevention measures and to preserve our public good by physical distancing, face masking, and practicing hygiene. Thank you so much for your attention.
Thank you, Professor Christie. I'll now move on to our next speaker, Dr. Joshua James Anzinger, did his undergraduate degree at University of Nevada, Reno. Did his PhD at Rush University, Chicago, Illinois, and postgraduate training involved his postdoctoral fellowship at National Institute of Health, uh, teaching fellowship at the Smithsonian Environmental Research Center. Currently, he's a senior lecturer at University of West Indies Mona Department of Microbiology. He has held various positions in the Department of Microbiology at the UWI Mona, including head of the virology section. Is currently director of the Jamaica affiliate Global Virus Network. He has given several lectures to physiotherapy and medical students in the Faculty of Medical Sciences, UWI Mona, an adjunct professor in microbiology at Georgetown University and the National Institute of Health and Rush University. Conducts examination duties supervising MPhil, PhD, and DM students. Also does training and research with the MSc, MPhil, PhD, DM, and undergraduate medical technology master's students. He's a member of the American Society for Microbiology, member for the International AIDS Society. Has been given several honors and awards, numerous from various institutions for lectures on HIV, dengue, Zika, atherosclerosis, including the University of the West Indies, Mona, PAHO, NIH. Yeah, he has an extensive research portfolio. Were we to begin to list that, it would take up the time for this lecture. Done research on HIV, macrophage fluid-filled pinocytosis of LDL, agonist-specific regulation of inositol phosphate metabolism in cardiac endothelial cells, and production of nucleoside diphosphate kinase by tumor cells as a mediator of metastasis. And he has an extensive research portfolio and presented posters, and he's a member of several editorial boards and extensive public service. Once again, it's my honor to present Dr. Joshua James Anzinger. Thank you.
Thank you so much for that very generous introduction. Just making sure that everybody's hearing me before I go on. Could someone give me some feedback there, please?
You're good. Go ahead.
All right. Thank you very much. So I am going to talk about variants of concern for SARS coronavirus 2, which I think is a very timely topic that you have chosen for me to talk about, especially considering the news yesterday that the variants that are in the community and spreading locally, the B117 variant that we're going to talk about. All right, I do want to provide just a little bit of background so we're all on the same page. Really, if we talk about variants, we have to talk about mutations. So I just want to spend a moment talking about that and from the perspective of viruses. So mutations are going to be really a critical aspect of many viruses. All viruses are going to mutate, some more than others. And for viruses that are very widespread, we have lots and lots of viruses. So we're going to have lots of opportunity for mutation, which can, from the virus's perspective, lead to a favorable adaptation. And so here, just in this example, we can say that this is SARS coronavirus. We have different mutations, 1, 2, and 3. On the left, this person has been infected, let's say, with the ancestral strain. But due to mutation, you may have some that basically there's no change. So the sequence may change, but the protein may not change. And so that would have no effect. Some may be make it less favorable for the virus, and some may even be non-viable, as we have in this example here in 2. And then much more rarely, what will happen with the mutation is every once in a while, in a rare event, you will have a mutation that will actually have an effect that is favorable from the virus's perspective. In this case, I've just shown you in 3 that we that has resulted in an increase in its. And so this person now goes on to infect another person, which becomes infected. Obviously, 2 is non-viable, so that is not going to be a problem for that person. But this person may be infected with the ancestral, but also the mutant strain, which begins to replicate at higher levels and outcompetes the ancestral strain. So if this person now has forward transmission to the next person, you may end up with a situation that basically the great majority of the virus is being replaced by this mutant strain. And this is really going to be a critical aspect of what we're talking about for variants. All right, so there's a lot of very confusing nomenclature that I think needs to be a little bit tied up to get it to the public, basically, because the nomenclature is a little bit confusing, certainly as it relates to these variants that we'll talk about momentarily. All right, so when we're talking about a virus species like SARS coronavirus 2, this is basically a group of viruses that have properties that can distinguish from other species. And this is come to by a group of international experts by the International Committee on Taxonomy of Viruses. Now, within that species, all viruses are going to mutate, as I said. So this is going to result in change in genetic sequence. And this will lead to variants. So variants are actually going to be a normal part, basically, of all viruses replicating. There's going to be mutations, but really, oftentimes, this is really neither here nor there. It may really not make much of a difference. Although there's some subtle differences within a single person, there may be lots of variants, but really these have no great effect. What we have an issue with is some variants can become more favorable from the virus's perspective, for example, be more transmissible. And these are where we end up with the designation variant of concern that gets highlighted by an international organization like the WHO. And it's basically just a variant with potential public health implications. Now, variant and strain are sometimes used interchangeably. I don't think there's any really agreement with scientists. Strains are kind of a funny sort of situation in virology world because it's sort of not well defined on who really names them. And so these are kind of used interchangeably, sometimes strains and variants. But as of now, I don't think there's been agreed upon that we have necessarily different strains. All right, so let us just move to an important aspect of the virus. I'm not going to talk about the entire replication cycle. I don't think that's necessary, but I do want to point out this one in particular protein of the virus called the spike protein. And this is really going to be one of the very critical proteins for the virus. So this virus is going to facilitate the binding of to its receptor, which is going to allow the virus to get into the cell and to replicate. So this is an absolutely essential protein. Without this protein, the virus cannot bind and enter cells. All right, so this is an essential protein for the virus. Now, when we are either naturally infected or we have a vaccine that is against the spike, we create antibodies. So there's cells in the body, B cells that produce antibodies, and these are going to bind to the spike protein, all right, which we see here. So this is just for simplicity, just showing one, but this virus will be covered with antibodies. And in particular, we have different types of antibodies, those that can bind to different areas that are non-neutralizing. And then we have, as an example here, a neutralizing antibody. And this is going to prevent the replication of this virus into the cell. And oftentimes what this is going to do is going to physically block, basically, in this case, the spike from interacting with the ACE2 receptor. So we've completely blocked infection of the cell. And of course, these are why people keep talking about these neutralizing antibodies, because these are the most important from the perspective of preventing infection in the first place, all right? So a mutation from the virus could really result in a decrease in the ability of neutralizing antibodies to potentially bind to this spike protein, and we'll get back to that momentarily. Now, to get to our SARS coronavirus 2 variants of concern, really our first one was one that really began to emerge in Europe, and this was a mutation D614G. So that basically means we have a particular amino acid, aspartic acid, at position 614 of the spike protein, and it mutated to this glycine at position 614, all right? And what you see, obviously, is it has now, this is basically showing worldwide, relative worldwide, all the SARS coronavirus 2 circulating in the world. It's been basically this ancestral strain has been, or variant has been replaced by the G614. And we now know that this has an impact on increasing the ability of the virus, the spike protein, to bind to its ACE2 receptor. All right, so here you can see this is just the string of amino acids, and here you can see the ancestral strain, and then here you can see the mutation. So it's just this one change in this one amino acid from aspartic acid to glycine. And what that has an effect on doing is favoring now the spike protein to be in a more open conformation, which has been found to increase its interaction with the ACE2 receptor. And now experimentally, in both cells, in a tissue model, and also in animal model, if you put in the ancestral strain, the D614, or the ancestral variant, with the G614 in a 1-to-1 ratio, what happens is you end up with your output on the right is much more the G614 strain. So this appears to be a much more fit virus. Presumably this is why there's a replacement of the ancestral G614 or D614 with G614. So that was our first variant. And I'm going to show you some more variants momentarily, but I just want to make sure we're on the same page, because the next slide is going to be quite complicated. I don't think we need to delve into it too deep, but I do just want to make sure that we have some idea of what we're going to see, because there's going to be a lot of information presented. So this is just a very obviously oversimplified phylogenetic tree. And what is being done here is we're determining how similar viruses are to each other based on genetic sequencing. And so this is just an example of, this would be many more nucleotides that we'd be looking at in a particular gene. But this is just to give you the idea. So we're comparing each of these three with the sequences. And we find here, just in this example, that 2 and 3 share 7 nucleotides in common, where 3 and 1 and 1 and 2 only share 4. And so basically this is telling us that 2 and 3 are more closely related to each other than they are to 1. So these lines basically are indicating things that happened in the past. And as we go from left to right, so on the left, these are things that no longer exist. And on the right, these are things that are now with us presently, viruses that are with us presently. Now, I wanted to just give that a little bit of introduction just to make sure that we kind of have an idea what we're looking at, because obviously this is quite a larger phylogenetic tree. This is the sequences of SARS coronavirus 2 throughout the world. So just as I said on the left here, this is now going to be basically the start of the identification of SARS coronavirus 2, the first sequences in 2019 in December. And as we go from left to right, we can see that there's changes in the virus and new lineages are forming. And as we go all the way to the right, then we see this is present day in the most recent sequences. Now, if we look here, I've highlighted our variants of concern. These are the major variants of concern right now that are spreading to some degree worldwide. On the top in orange, we have B117. This is the variant that was first identified in the United Kingdom. We try and stay away from naming countries because of the stigma. However, it's clear that that is failing because there's just too much. It's very complicated in terms of the nomenclature. So you can even see on this phylogenetic tree, there's different names. So B117 is also referred to as 501YV1. So this nomenclature needs to be really tidied up for public consumption. And so we have our B117 in orange. In red here, we have the P1 variant that was first identified in Brazil, and B1351 that was identified first in South Africa. Now, fortunately, we see that out of all of these sequences that are circulating in the world at this point are still the minority, fortunately. If we look to see where we find these, so here if we start on the top left, our B117 in the United Kingdom was first identified in the United Kingdom. You can see that this has spread quite a bit. So the dark color is indicating that there's local transmission of this variant, and the light color is indicating that it's imported only. So for example, in Jamaica here, this is not updated with yesterday's news. The first identified B117 were from travelers from England that were identified with B117. All right, so it was not known at that time that there was local transmission, but it was clear that there was importation, at least on that particular flight. And we can see that this is really spreading all throughout Europe, into Asia, South America, North America. This one is really becoming very, very prevalent. If we look at our one on the right, B1351 in South Africa, obviously it's present in South Africa and neighboring countries, but we're also starting to see it in Europe and North America as well. P1 is the most recently identified, and it thus far is not as highly prevalent as the others. So clearly in Brazil, a few other places, Mexico, South America, and a few places in Europe, but not as prevalent thus far. So B117 is really the one we really need to watch out for right now, especially in the Caribbean region, given the recent news, and especially in Jamaica. So again, back to our phylogenetic tree, I do want to, so all of these dots now, I've just highlighted all of the sequences that have come out of the Caribbean, and the great majority of these have come from a colleague on the COVID-19 task force, UE COVID-19 task force, Professor Christine Carrington. So she's working in conjunction with CARFA, basically piggybacking on these samples are sent from CARFA member countries, and she's an expert in molecular virology, and she takes these samples in her lab and sequences those. All right, so we're very fortunate to have that level of expertise and that to be able to get these sequencing results. And what we find here is, I've just highlighted our variants again. Fortunately, we have not seen anything up to yet of B1351, the variant first identified in South Africa. P1, this red dot actually is in the B117 P1. And then if we look, we have sequences of B117 clearly in the Caribbean. So these are Caribbean countries, and the most recent data that just came out yesterday has not been added to this. So there will be more, but we can clearly see that we have B117 in St. Lucia, Jamaica, which we now know that is circulating within the community based on the news that basically almost all of the infected cases that were sent, the samples that were sent were almost all B117. So clearly this is very, very prevalent in Jamaica. Barbados and Aruba also showing B117. So clearly we have B117 in the Caribbean region, and this is something that we really need to pay attention to right now, but also keep our eye on the other variants. So getting back to what I said about our neutralizing antibodies, and I said that mutations can be advantageous for the virus, which gives us problems in that we can have a mutation that makes the neutralizing antibody perhaps not bind as well. All right, and this gives an opportunity for the virus now to actually infect a cell. So I've put together all of our what we've seen so far in preprints, and half of it's about in preprints, half of it's through publications that have been peer-reviewed, of where we stand with neutralizing antibodies and the different variants. All right, so I've just focused on almost all of the data is on the first three vaccines that came out: Pfizer, Moderna, and AstraZeneca. And so you can see there's lots of information, fortunately, on B117. And what we see overall is that Pfizer, there's some studies that show no change. Moderna was no change in the two studies. A few studies in Pfizer showed a modest decrease in neutralizing antibody level. If we look at our AstraZeneca, we have a modest decrease in one study and a much greater 9-fold decrease in another study that I'm going to get back to on the next slide. If we look at our B1351, all right, so clearly, just looking at this data, we have a consensus that we have decreased neutralizing antibodies basically in every single study. And this is something to really be concerned about and keep our eyes on B1351 and its potential now that we are losing neutralizing antibodies, that perhaps we would be able to, the vaccine not be as effective. I'm going to talk more about this momentarily. And then P1 is the newest variant, and there's really, at least up to a few days ago, only one study that showed a modest decrease in neutralizing antibodies in the Pfizer vaccine. So remember this 9-fold decrease in the AstraZeneca. Let's get back to this. This doesn't necessarily mean that we're running into big problems, all right? And so if we look at our B117, which is clearly something we need to pay attention to in Jamaica and in other Caribbean countries, we look at the AstraZeneca vaccine, does it remain efficacious against B117? And the very, very good news, considering we have vaccination starting tomorrow in Jamaica, is the vaccine efficacy is very much almost the same. All right, and I don't think these were necessarily statistically different. So 84% efficacy for non-B117 and that is non-variants of concern, and about 75% for B117. So this is excellent news. Also, I just wanted to highlight, this is one of the earliest studies that basically looked to show not only is there protection from a person that's vaccinated from getting infected, but there's also a public health implication because they've shown that there's a reduction in duration of shedding and viral load if I were to be infected as a vaccinated person. All right, and this is very good news because this is probably means we're going to slow onward transmission. All right, so the vaccine will not necessarily protect you from getting infected with the virus. It will, in some cases, and will likely lead to asymptomatic infections or mild infections if you do get infected with the vaccine. Another cause for concern would be the possibility that we are in a B117 naive population, and this gets introduced, and perhaps we start seeing a rebound in cases because we start seeing the ineffectiveness of vaccine, which we don't think based on the left is happening, but perhaps also reinfections as well. And so a good place to look here actually is the United States, where they have very robust sequencing data now. And we can see that in California and Florida, the states of California and Florida, this is where there has been the most B117. And you can see it is really shooting up fairly rapidly. The good news, if we look on the right, this is the, I think the 7-day average of cases. You can see that basically, even though that we have the B117 increasing very rapidly, we don't see the increase in cases. All right, so basically what has happened is it looks like it's basically replacing this, the variants or the virus that's circulating within that population, but we're not seeing rebounding cases. So this is excellent news that although the B117 variant is in the Caribbean and Jamaica, that we will be able to control it. I do want to also just indicate that although antibodies are clearly important, and neutralizing antibodies in particular, they're not the entire immune system, but we do clearly want that to prevent infection in the first place. But if we are infected, we're still able to have an immune response. And this is clear. B cells are the ones that produce antibodies, but in people that lack B cells or have in B cell depletion therapy, they're able to clear the virus still. And there have been many studies now that have showed that basically people that have been infected with no detectable or very little neutralizing antibodies can also clear the virus. And so from an immunologist perspective, this is not surprising because we know there's more to the immune system than just B cells, but we really want to be in the situation where on the right, where we have our virus completely coated with antibodies, and so we have these neutralizing antibodies that prevent infection. But if we do have an infection, we also have T cells that are able to act, whether we're infected already naturally or through vaccination, that will be able to now identify and destroy infected cells. All right, so I'm going to just summarize basically what we know now about the 3 variants. So I spent most of the time on the B117, obviously because of the implications that it's in the Caribbean region now. But as we see here, we have a number of mutations. We talked about some of them. We also have all of them share another mutation in addition to the 614, and this is the 501 Endo-Y, and this, like the 614, increases the interaction with the ACE2 receptor. We have a number of other mutations. Some of these actually have a role in evading immunity and neutralizing antibodies. And the transmissibility, we now know that B117 definitely is more transmissible than non-B117 ancestral strains, somewhere 50%, perhaps more. We don't have enough information on B1351 and P1. It's not established. The lethality, I think there was actually just a preprint that just came out yesterday, and it's starting to look more and more like there is actually an increase in mortality with B117, unfortunately. There is not really universally agreed on, but it does appear to be an increase in mortality now. Not clear, not enough studies. We don't have the studies and data yet for B1351 or P1. And then finally, for vaccine efficacy, we talked about the B117. Our vaccines are going to give us, are still efficacious. We might have a slight decrease. I mean, but these are not huge numbers. And then our P1 is likely, but we have not established that. Still need to get the data. But really concerning is the B1351, in that we did definitely see reduced vaccine efficacy. And in particular, the AstraZeneca, there was basically almost no efficacy whatsoever against the B1351 variant. So this is very concerning. In this study, they did not have hospitalizations and severe disease, so it remains unclear whether the AstraZeneca vaccine may still protect against severe infections, all right? But at least in terms of moderate disease and below, it was very, not very good at all, almost no efficacy, unfortunately. So to conclude, hopefully I've convinced you that sequencing is very important, and identifying these variants inform public health. For the majority of circulating coronavirus across the world, I think you saw in that phylogenetic tree, vaccines are going to remain highly effective. So this is great news. We talked about B117 variant of concern is present definitely in Jamaica with community transmission, and likely other CARFA member states, even in addition to the ones that have the data. Good news with the B117 is the vaccines, including the AstraZeneca, which is one that is more widely used in the region. It remains efficacious. And some of these variants of concern can evade immunity to some degree. In particular, worrying one is the B1351 of the South African variant. And because of this now, at least these three companies I know, the early ones, Pfizer, Moderna, and AstraZeneca, are actually already working on updating them to update the sequences to being matched with these variants. But it remains to be seen how long that's going to take to go through the regulatory body and get those available. But the good news is these are not very prevalent at this point in time. I do want to just finish that I am a part of the Global Virus Network, which is a international group of international experts in virology. And there is a lot of resources on the website with information on vaccines as well as the variants. You can just go to gvn.org or this site in particular on the bottom, which will link you directly there. So I want to thank you for the invitation to talk on this meeting.
Thank you, Dr. Anzinger. With time, I know back over to you, co-chair Dr. Harvey. Thank you.
Thank you very much. I think we have had two excellent presentations looking at the vaccines and the new strains and the challenges that it will bring. So this takes us to our third presentation, looking at the real-life impact of the COVID epidemic. And we have with us Dr. Alverston Bailey, who is a graduate of the University of the West Indies, and who has also done his postgraduate training and certification in occupational medicine. He has worked for the past 4 decades in this field, and he's here to speak with us today about COVID-19 and the new world of work. Over to you, Dr. Bailey. Could you unmute?
Thank you very much, Mr. Chair. I trust that you can see my screen. If not, could I ask the moderator to just activate my screen? Okay, could you go to full screen? Thank you. I've been asked this afternoon to make a brief presentation on COVID-19 and the new world of work. And is it time to rethink the global public health order? Next slide. Next. Now, we know that COVID-19 is both a global health crisis and an international economic threat. The worldwide lockdown of businesses and industries that were implemented and mandated to curb the spread of the virus have generated a wide array of unique and fundamental changes for both employees and employers across the globe. Next. At the individual level, populations of shutdown affected employees have turned overnight into work from home employees, essential or life sustaining workers, example, emergency room medical personnel and supermarket staff, or furloughed or laid off employees seeking the nation's specific equivalent of unemployment benefit. Next. We will spend the next 20 minutes looking at the importance of moderating factors such as age, race, ethnicity, gender, personality, family status, and culture on COVID at the workplace. Next. We'll also be looking at emerging changes in work practices, such as mandatory working from home, virtual settings, and unprecedented scale, which is now as acquired. Next. We'll also be looking at the economic and social and psychosocial impact in the wake of COVID, resulting in unemployment, mental illness, and addiction. Next. Now, just to quickly remind you that the clinical characteristics of COVID are many and varied, and we move from fever, dry cough, fatigue, all the way through to no symptoms at all. And it's important to recognize that up to 40 to 45% of persons with COVID-19 are asymptomatic. Next. Now, with respect to the clinical outcome, as shown in this slide, which was produced from Wuhan, China, and posted in January 2020, it indicated that pneumonia affected almost 100% of persons, ARDS 29%, acute cardiac injury 15%, secondary infection 12%, ICU admission was 10%, those who required mechanical ventilation were 39%. A significant number, however, was discharged, which is good, but over 15% died and 17 remained in hospital. Next. Now, I just want to quickly show you what's happening in Jamaica. And you can see that as of February, we are seeing a significant increase in confirmed cases. Next. And the other slide actually also indicates the significant increase. And we're looking here essentially at a small spike, a medium-sized spike, and a very large spike. Next. Of interest, with respect to the Jamaican experience, you can see that the primary urban areas like Kingston and St. Andrews, St. Catherine, and St. James have the highest number of COVID cases. Next. And interestingly, too, in Jamaica, more females are affected than males. Next. Also interestingly, as one could perhaps predict, the largest cohort of infection is within the young, between age 20 to 39. Next. So let us now take a look at the impact of COVID-19 on the workplace. Next slide. The question that one sometimes asks, which is easy to understand, is why do persons get infected at workplace? And it is obviously due to exposure while traveling to work, doing work-related travel to an area with local transmission, and on the way to and from work. Next. I thought this slide was particularly interesting because it actually showed the risk of infection at the workplace. And it actually indicated to the right that the professionals who work in the health sector have the highest prevalence of COVID, and the bubbles in blue are those who are not in direct contact with sick persons, and in fact, the persons with the least risk for exposure to COVID-19 are CEOs and managers. Next. Next, please. Next. Let us take a look at a study that was done in the UK, looking at 120,075 workers, and it showed that of those infected, 29.3% were essential workers, 9% were healthcare, 11.2% were social and education workers, 9.1% were other essential workers, and of interest, white, British Isles and other participants accounted for 92.2% of the study, and South Asian and Blacks only 2.6% and 2.7%. Next. But of interest, in comparison to non-essential workers, healthcare workers had a more than 7-fold greater risk of severe COVID-19, and social and education workers also exhibited a higher risk, and other essential workers also had slightly higher risk compared with non-essential workers. Next. Now, interestingly, men, South Asian, and Black ethnic groups, and those who are described as socioeconomically disadvantaged, and the least educated groups had a higher risk of severe COVID-19 compared with women. They also showed in the study that work-related factors, including shift work and manual work, were also associated with a higher risk of severe COVID, along with being overweight or a previous smoker. Next. Next. Now, if you take a look at this slide looking at essential occupational groups, the study showed that medical support staff had the highest risk of severe COVID-19, followed by health associate professionals and health professionals. Next. It's also important to note that among social care workers, the risk was also elevated, and transport workers exhibited a 2-fold higher risk of severe COVID-19 compared with non-essential workers. Interestingly, in this study, there were no strong association observed for police and protective service, food, or education workers. Next. Next. Now, managers, senior officials, associate professional and technical occupations also had a high risk when we looked at major occupational groups. Personal service occupations were associated with high risk, and process, plant, and machine operators also had a high risk. Next. So with respect to the major occupational groups, we need to pay particular attention to professional, administrative and secretarial, skilled trades, sales and customer service, and elementary occupations. Next. Next. Now, with respect to a study done in England and Wales, it showed that in men, with respect to morbidity, elementary trades and related occupations had a fairly high level of death, followed by protective service occupation, followed by textile, elementary, administrative, and service occupation. And the least ones were skilled, metal, electrical, and electronic trades. Next. I thought it would be interesting to take a look at this, to look at COVID-19 deaths in England and Wales by job classification. And to my right, it showed that the highest death occurred in carers, and the least were those who were not in contact with sick persons. Next. Now, with respect to COVID-19 risk for men, in England and Wales, the male death rate per 100,000 was highest, interestingly, among restaurant managers, followed by care workers, followed by metal workers, followed by food manufacturers. Secondary teachers had fairly low death rate, and all teaching roles had a fairly low death rate. Next. With respect to women, the female death rate per 100,000 in England and Wales was highest among care workers, followed by social workers, followed by government admin, retail assistants, secondary teachers, and all teaching roles. Next. Now, I thought this slide was particularly interesting. We're looking at the concept of working at home, and it indicated that managerial and professionals are the ones who primarily worked at home, and those involved in routine and manual work hardly ever worked at home. Next. This again is the same slide showing you that the labor force with respect to work at home actually were primarily the labor force and not the managerial group. Next. Let's take a look at some moderating factors that is impacting on COVID at the workplace. Next. We know that COVID-19 presents a number of challenges for age at work and aging workforce, according to Rodolph et al. Next. Preliminary analysis of COVID-19 indicate that older people are disproportionately at risk of dying if they are infected, thereby warranting substantial attention to age. Next. And this slide actually is self-obvious that the persons who are dying are primarily those between 60 to 80 years old, even though the majority of those who are infected in this particular slide are between the 40 to 69 age group. The majority of those who die are between 70 to over 80. Next. With the Jamaican experience, this actually was again to emphasize that the majority of those who are infected are in the younger population. Next. This slide also emphasized with respect to hospitalization, death, and ICU admissions, it is primarily those between 70 to 80 who are succumbing to this malady. Next. Next. Now, this particular slide also is quite interesting because it actually indicated, again, to repeat myself, that age is primarily, the age effect is primarily the elderly, but it also shows that those with cardiovascular problems, those with diabetes, respiratory problems, and hypertension are at high risk. And again, it shows that males are also at high risk. Next. Next. Now, therefore, with respect to recommendations, we recommend that all workplaces optimize employee human capital across the lifespan and strengthen internal labor markets through cross-age mentoring to help to deal with the impact of COVID-19 on aging. Next. With respect to ethnicity, this particular slide is quite interesting because it actually shows that COVID-19 associated hospitalizations are highest among people who are non-Hispanic, American, Indian, Alaskan, Native, and non-Hispanic Blacks, and Hispanic and Latinos. Next. The next slide also indicates that highest percentage of death with respect to population is occurring in the Black population. Next. And this also shows quite clearly that in this particular study that Blacks followed by Asians, followed by whites, were the ones that are primarily affected. Next. And this again emphasizes the point that the largest percentage of persons affected by COVID-19 are Blacks with respect to their population, 5.1 in this instance, and with a population of the society of 3.7%. Next. And this is a very sobering slide, which I'd like us to pay attention to, that with respect to this particular study in the UK, it showed, strange enough, that the actual hospital deaths in this particular age group was primarily among Black Caribbean persons, followed by Black Africans. Next. So therefore, employers need to create an environment where all employees, including racial and ethnic minorities, realize they can contribute to the organization goal irrespective of age or ethnicity. Next. This slide actually indicates that there are higher fatality rates for men, yet there are economic and psychological reasons to suspect that women face far greater occupational risk. Next. Next. With respect to gender, the evidence shows that women experience more distress from stressful life events, particularly the ones affecting others. And given the well-established link between distress and performance, Bagat has shown that work disruption may be more severe for women. Next. The recommendation by Campbell, therefore, is that women should play a critical role at this point in time because they are more adept at communal orientation, they have higher sensitivity to risk, they have higher conscientiousness, and they're more attentive in terms of communication styles. Next. 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 With respect to family, research has shown that in heterosexual couples, women typically do the majority share of the household work, and this can lead them to stop their particular or opt out of their career. Next. Given that partners are known to play a key role in supporting or undermining each other's careers and developing professional identity, it is important, therefore, to understand how couples manage the emotional labor of dealing with anxiety provoked by this pandemic. Next.
1 minute.
Therefore, recommendations is that working couples should communicate openly about how they divide household labor and childcare. Next. With respect to personality, the evidence has showed that personality traits does impact on coping with the pandemic. Personality traits such as extroversion, agreeableness, openness, conscientiousness, and neuroticism. Next. Therefore, Schiller and his team show that lower levels of extroversion are reported in countries that have historically suffered from higher levels of infectious disease. Next. Therefore, conscientiousness contributes to adjustment by fostering commitment and perseverance towards more predictable, non-immediate work goals. Next. Conscientiousness, therefore, offers potent workplace benefits. And unpredictability, on the other hand, increases job complexity, which decreases conscientiousness. Next. Therefore, organizations should strive to reduce unpredictability, to provide clarity to job roles, to help restore the benefit of traits such as conscientiousness, and segmenters will need to tolerate non-work interruptions when working, while integrators will benefit from some segmenting of time and space. Next. We also know that cultural differences play a critical role in adapting to COVID at the workplace. Next. Next. And therefore, we recommend that leaders need to understand how to be ambidextrous regarding social norms and know how to employ tightness and looseness in order to cope with this pandemic, which is unfortunately, because of time constraints, I'll have to end my presentation now.
Excellent presentation, Dr. Bailey. Thank you very much. And we apologize for the limited time, but I think we have been having a good session so far. Finally, we're going to have with us Professor Winston Davidson, who is also a graduate of the University of the West Indies and have had significant studies in many other places. Dr. Davidson has been a practitioner in public health for over 40 years and has studied at the Liverpool School of Tropical Medicine and Hygiene, and has done hundreds of publications, has innovated telemedicine infrastructure, including what is called a Doctor on Call platform, and has really been an icon in public health in Jamaica. He has done a number of things like the development of the National Primary Healthcare Program for Jamaica, initiating the new National Immunization Policy back in 1976. And he actually started the overall immunization programs and program plans for Jamaica. He has developed the Jamaican Caribbean model for integrated drug demand reduction programs. But he's also the proponent of what's called the 4 stages theory. And he is going to talk to us today about rethinking the Global Public Health Convention in today's world in the light of the COVID pandemic. So Professor Davidson, we are honored to have you present to us today. I hand over to you. Unmute.
Can you hear me? I need some feedback. Can you
Yes,
see my
Prof,
slide?
Yes, Prof, go ahead.
Can you see my slide?
Yes, go ahead.
Okay. The first slide looks at the paradigm shift in public health thinking, which needs to take place if we're going to move the 21st century public health into a phase where we begin to understand the connection between all types of diseases, and where we see this connection grounded in our relationship to the environment. So therefore, firstly, we need to look at the World Health Organization's definition of what health is supposed to be. And this definition from 1946 has been a part of the preamble of the Constitution adopted by the International Health Conference in New York since the 19th to the 22nd of June in 1946, almost 75 years ago. And this definition has not changed. It has never been amended. And the fact is that, I quote, the definition is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The problem that I have with this definition over all these years of practicing public health is that this definition mentions absolutely nothing about the environment. And so this next slide looks at the objective of the methodology, which, because in the interest of time, I'm going to flip over some slides because this can be read after we are finished with the presentation. Now, there are 3 questions, critical questions that need to be asked. First of all, the definition makes no mention of human health and its relation to the environment. Is this gap a fundamental conceptual flaw in the WHO definition of health? If so, what does the 4 stages theory present? And the 4 stages theory is what I'm presenting and justifying as part of, or rather, the beginning of the solution to deal with this particular very important fundamental flaw in the practice of public health, the practice of medicine, and of course, in general practice, in the practice in general. And so therefore, that's the first question. What does the 4 stages theory present as an updated or alternative definition? The second question is, the principles of prevention which inform the practice of public health were derived from the 1946 WHO definition of health. And when you look at this gap, what limitations are manifested in the existing theories of prevention in public health practice and in the application therefore, of the science of epidemiology. What I'm contending is that there are also problems with the existing theories of prevention and problems with the scope of the practice of epidemiology. So we're going to answer that question. The third question is that the 4 stages theory of prevention presents a paradigm shift, a conceptual and analytic framework for correcting the gaps in definition of health, changing our understanding of the principles of prevention, the practice of public health, and the scope of the science of epidemiology. What is the evidence to support this? That's the question. What is the evidence to support the validity of the 4 stages theory? And what is the justification for the claims of its impact on public health practice, especially the scope of epidemiology? So these are the fundamental questions which we will answer during the course of this presentation. First of all, the first question, the WHO's definition of health. You all know this definition. It is a state of complete physical, mental, and social well-being. What do we mean by well-being? And not merely the absence of disease or infirmity. The 4 stages theory of prevention, definition of health, having looked at what we have, in fact, has been the definition by the WHO, presents this particular modification of this definition, dealing with the gap that is observed and not only, but also in our practice over 40 odd years. And those of us who have been in public health for a number of years know that this is a fundamental gap. And so what is this proposal? A state of physical, mental, and social well-being through the harmonious adaptation of humankind within their environments, and not merely the absence of disease or infirmity. This definition captures the essence of the whole process of adaptation of the human species on the planet. It does not only capture the essence of it, but it is saying that if your adaptation is harmonious, then your outcome will in fact be sustainable. If it is not, that is where you're going to get harm, disease states, etc. The question is, how do we proceed? So we have the 4 stages theory, therefore, has presented a definition. The next aspect of the question which was supposed to be answered is that, what is it? What has been our history since that time of the core question of the what is meant by the question of the principle of prevention. And you have to look at the pioneering work of Level and Clark. Everyone who does public health have looked at these pioneers of prevention, dealing with the question of on the basis of the definition of health. And this is reflected in the review of the work of these 2 pioneers from 1953 to the present, a period of 70 odd years. By 1957, the evolution of the definition of prevention, or the theory of prevention, by Level and Clark, culminated in this work, which is a report by the Commonwealth Fund, Harvard Press, 1957, using the terms for the first time, primary and secondary prevention, and health promotion being defined as health maintenance or maintenance of health. In other words, the essence of it was that by 1958 to 2001, we're still using this particular prevention model theory, which I refer to as the 3 levels theory of prevention, because primary refers to health promotion and specific protection. Secondary relates to early recognition and prompt treatment, and tertiary relates to disability limitation and rehabilitation. The problem is that this particular definition or preventive or intervention measure or theory of prevention is essentially a disease profile prevention intervention measure, because it does not in fact speak to wellness in a generic sense as to what it is and what health really is. The next theory was a theory from Strasser, which he coined the phrase primordial prevention. And what he said was risk mitigation, especially those engaged in cardiovascular diseases, was the key to primary or primordial prevention. Secondary prevention was early recognition and prompt treatment, and tertiary prevention, disability limitation. My problem, even with this disease prevention model, is that if you try to superimpose fundamental epidemiological principles, such as incidence, prevalence, and of course, averting chronicity through rehabilitation. Where is the incidence here in primordial? Because it says mitigation, prevention of CVDs. Does this mean early detection and early diagnosis? If it does, then it would accord with what we refer to as the incidence or new cases of disease. But it doesn't. It's not specific enough. And so therefore it's not aligned to the first morbidity stage of epidemiology. Then secondary prevention relates to early recognition and prompt treatment. But early recognition and prompt treatment is, in fact, somewhat aligned to the prevalence of the disease, which is in all cases old and new. And so therefore, this is an alignment with the epidemiological principles. Tertiary, of course, rehabilitation. Now, where is wellness? Where is that particular position, and where is the environment? The 4 stages theory begins with a value chain. In other words, it looks at, the theory states that there's a health and disease continuum. It's not, the disease position is never just dropping out of the sky or taking place by itself. At some point, in fact, throughout human history, there has been stages of adaptation to the environment, and so therefore a state of well-being or harmonious adaptation. However primitive it was, it existed. Otherwise, the species, human species, would not have existed. And so we define in the 4 stages theory, in this value chain, the first stage, A, being pre-primary or adaptation. The second stage being primary or decreasing incidence. The third stage being secondary or decreasing prevalence. And the fourth stage being rehabilitation. And we have identified that. And this was developed as far back as 1992. And so therefore, the new paradigm of the 4 stages theory of prevention identifies pre-primary prevention as the fundamental point of departure and the category of harmonious adaptation, which is pre-primary prevention, and also a category of wellness. And so the 4-stage theory of prevention has 4 stages, not 4 levels, 4 stages, because we see it as a continuum of pre-primary, And you will see that pre-primary is talking about building harmonious adaptation capacity and building resilience through healthy lifestyle practices. But it is standing on its own as a category. This paper, which is being presented, will establish the evidence for pre-primary prevention as a categorical aspect of the prevention profile. Primary, of course, risk mitigation, etc., early detection, treatment of cases, and as we go, we have secondary and tertiary prevention. And so therefore, the 4 stages theory is building on what exists, while at the same time attempting to begin to address some of the glaring, not only philosophical, but the glaring scientific flaws, not only in definition, but in structure and organization. And so ultimately, the 4 stages of prevention framework of prevention is based on universal public health and epidemiological principles. Here we see pre-primary prevention, which is a state of health or well-being and is harmonious adaptation of humans within the environment. And this is maintained by a healthy lifestyle in maintaining health and wellness and building health capacity. But there's a continuum between pre-primary prevention and primary prevention, where we have now the disease model of primary prevention, secondary prevention, and tertiary prevention. I won't go into all the details, but you will see the institutional intervention prevention responses, the non-institutional prevention responses, and of course, the rehabilitation. But all of this is located both in communities and in institutions within the country. Next slide. And so I'm going to focus on the pre-primary prevention in order for us to understand what we mean by wellness and what we mean by harmonious adaptation. All of you who are listening here, who are practitioners, know one thing, that presently we do have 2 epidemics that are raging, pandemics that are raging in the world today. A pandemic of chronic non-communicable disease and a pandemic of communicable disease. And some of you are engaged in HIV, but now the one that is taking center stage is, of course, the COVID. Whereas it is easy to see the relationship between the virus in the environment and as a zoonotic part of the zoonotic part of the environment, and its carryover into the human ecosystem. It is difficult to see the relationship between diabetes, for example, and the environment. Some of you will even say that diabetes has no relationship to the environment, not understanding that you will not understand or see this relationship if you still only have a disease perspective of the management of diabetes rather than a health and disease perspective managing diabetes. We will demonstrate and show you the relationship between the environment and diabetes and a number of factors related to associations which over time will establish a cause-effect relationship between the environment and diabetes mellitus in the same way that you have a cause-effect relationship between health, between smoking, lung cancer, and of course, the environment. As a matter of fact, it took 15 years of the Dolan Hill study to establish that cause-effect relationship using Miller's criteria. And so therefore, pre-primary prevention The theory, 4 stages theory, has identified as harmonious adaptation, well-being, whose outcome is always well-being, and is achieved through the practice of a healthy lifestyle. Let me move on. The definition of prevention, because I know that there's a problem with time, I will move to the next slide. And of course, the whole question of adaptation. What do we mean by adaptation? Adaptation is an unrelenting process of interactive change between humankind and the environment. And you don't have to look anywhere else but just to look at the COVID-19 virus and look at how the process of the COVID virus attempt at adapting to the new environment that it finds itself in, that is in the human body. And that process of mutation is a natural process of adaptation, which every single biological matter, every single species undergoes with the environment that it finds itself in. And so therefore, from mutation to becoming a variant is part of the march, of the evolutionary march of the virus, in the same way that adaptation to the environment is the same principle on which the unrelenting process of interactive change between humankind and the environment takes place. I'll move on. Let us look at the whole question of adaptation, of pre-primary prevention. Understanding the adaptation process. First of all, it relates to human behavior, and it relates to deeply embedded core values which form the basis, the essence of adaptation. And these are the antecedents of the way we behave in society and in the environment. As you can see, those persons who refuse to wear their masks, the social distancing, are part of the process on matter of maladaptation to the environment, and therefore their risk of succumbing to the disease is greater. And so a rational and sustainable preventive strategy cannot be developed without our understanding or clarification of what we mean by core values. What are the values of the persons who decide against using or conforming to the protocols that have to do with the threat by COVID to human habitat? And so therefore, the first thing that the pre-primary prevention has to deal with is to clarify what we mean by values. And this values clarification, it will be part of the attempt at being able to study in a scientific way how we can in fact enable the process of harmonious adaptation and wellness. And so I have drawn on a number of studies from the National Council on Drug Abuse studies that I did with the UN. And we see where we define deeply embedded values and, of course, nascent values. So the process of values clarification is necessary if one is to engage in meaningful planning of prevention intervention measures and strategies to achieve the desired health and wellness outcomes. Why is this so? Because without understanding values, core values, you can't understand human behavior. If you don't understand human behavior, then you can't understand how the human being reacts to the environment. Now, this particular process varies according to history and according to the environmental conditions itself. And these situations create the level of consciousness that causes human behavior. But I'll just run through the other stages of our understanding of pre-primary prevention by looking at other areas. The late Professor Carl Stone and myself worked on this, looking at values, norms, and personality development in Jamaica in 1992. And first of all, the relationship between values and human behavior have to do with the relationship between values, norms, institutions, which lead to drives, motivations, resulting in human behavior. So if you understand that about a community, and I'm going to be granular to understand where prevention has to begin. It has to begin at the interface where people live, work, and have their being. Then the pre-primary prevention, the study of human behaviors, must also deal with social forces, human values, norms, etc. And of course, deeply embedded core values by looking at the domains of social space and the influences within the country of the international and of also what we call popular culture and how it affects core values. Pre-primary prevention or wellness. What do we mean by that? Wellness has to do with dynamic relationship between human and natural ecosystems. The goal is harmonious adaptation or a state of health in which you are building health resilience. And I can tell you that it's not in this paper, but based on our research from the National Council on Drug Abuse, we discovered that there are 5 pillars of wellness that you can identify as part of pre-primary prevention. And let me do them quickly. The first pillar is good nutrition. The second pillar is physical exercise. The third pillar is coping with stress. The fourth pillar is restful sleep. And the 5th pillar is environmental harmonious relationship within the space, the living space that you have. If you have programs, personal programs relating to these 5, you are in fact on the right path. Because the approach from an epidemiological standpoint of dealing with the COVID is a different approach in dealing with diabetes mellitus. Why is this so? With COVID, you can have strategies, mass strategies, to deal with the spread of the virus and the disease. But with diabetes and chronic non-communicable diseases, to address that pandemic, it has to be on a case-by-case basis. And so therefore, these are 2 types of disease. One communicable, the other non-communicable. But the approach, of course, is different. And so we can move now to the core values, sustainable cultural expressions, behavioral practices, healthy lifestyle. So this particular slide begins to define pre-primary prevention from the standpoint of wellness. And of course, these are, yes.
We're running out of time.
Running out of time. All right, yes. Now, finally, I'm going through this final proof, right? The proof of the impact of environment and air pollution sources on the causation or the possible causation of diabetes, right? Here we have traffic-related air pollution sources. And here we have traffic-related air pollution markers. And we're going to do a review of all the literature. And we showed where air pollutants and type 1 diabetes mellitus, right? We find that ground level ozone, right, affects type 1 diabetes mellitus. In other words, persons exposed to ground level ozone have a higher incidence in California, not only in California, but also in many other countries. Also, the effect of sulfates, the effects of sulfur dioxide, nitrogen dioxide, and particulate matter. Also, air pollution and oxidative stress, which leads to the development of diabetes, and we could see this data that is there. Other data, not only oxidative stress, but also free radicals. We also have the immune system, the immune dysregulation, and therefore you begin to see the nexus between the immune dysregulation or the comorbidities and the COVID pandemic. The air pollution and autoimmunity. The air pollution I'm talking about, these are exhaust particles, with the main air pollutants in urban areas can affect the immune system. Exposure to these particles in utero and in early life affect the immune system development and conservation of immunotoxins. This from Japan. All throughout the world. In other words, what I've done is a review of the literature globally and found that there is consistency in the literature in different environments of showing the effect of air pollution on the genesis of gestational diabetes, the genesis of insulin resistance, the genesis of obesity and insulin resistance. And this data is here with all the references and type 2 diabetes, and also mortality, types 1 and 2 diabetes, air pollution, and chronic disease. And so we know that, in fact, pre-primary prevention is aligned with the science, is always aligned with the science of epidemiology, right? Right? And the standard definition of epidemiology, therefore, has to change, where we have looked at then, if we accept that the 4 stages theory has the data to support its validity, then you have to begin to understand that the scope of epidemiology has to change now to include exploratory data, the exploratory data that you will get from the pre-primary prevention. And so therefore, the epidemiological research will therefore, and this is how I structure that particular paradigm. So the 4 stages theory of prevention, the evidence presented is suggestive of the following: that the tenets of the 4 stages theory of prevention has enabled the creation of new thinking and expanded the frontiers in the management and practice of the principles of prevention applied to both health and disease states. The 4 stages theory has created the conceptual and practical framework for the unity, the integration, and continuity of both qualitative and quantitative methods of research in keeping with the paradigm of the health and disease condition. And that is why in public health today, we are talking about blended or mixed research. Not only quantitative, but quantitative and qualitative blended to get both the subjective and the objective manifestation. What is my recommendation to who? The WHO needs conceptual, philosophical, organizational, and structural changes, and interagency collaboration and best practice reforms to enable efficiencies and a modernization of global public health practices. This is an imperative for achieving sustainable community and environmental health. Finally, the presentation is proposing that a definition of health, as per the 4 stages theory of prevention, is vital and necessary to begin the development of a viable and universal sustainable public health reform process.
Excellent. Thank you very much, Professor Davidson. I think we can all agree that at some level, we need to look at the WHO, its function, and look at how this is reformed in going forward. And you're taking it to a very fundamental level, that is to change even the definition of health in starting to look at this fundamental reform of the WHO. So we want to thank you for putting that on the table. I think it's exciting, and we have to look at that. We're running out of time, but Mike, I think we'll ask those on the panel to just quickly answer a few questions, and then we will ask you to wrap up for us with the final 2 minutes. So there are some questions in the chat. Did you all have a chance to look at it, Professor Christie?
Yes, I can speak. Which one do you want me to address?
The first one about the vaccine.
Oh, vaccine nationalism. Well, it's very clear that it was the first world countries that have benefited most from vaccines. And therefore, the WHO and partners have established the COVAX facility to develop a way to make the global equity of vaccines, to make 2 billion doses available to over 190 lower income and lower middle income countries around the world, beginning in March 2021. These vaccines have to be pre-approved by the WHO or other regulatory agencies like the FDA and the EMA, and there are about 10 now that are under consideration. The Caribbean is included in this facility, the COVAX facility, with funding from CARFA, individual governments, and the private sector to assist. And so far, some 14 countries are slated to get their vaccines, the first tranche of vaccines here in March. So we are very concerned, and we're doing what we can to make sure that we benefit. There was another question, I believe, that had to do with HIV. All of the studies, all four vaccines included patients with HIV. Pfizer, Moderna, and the Oxford AstraZeneca study included somewhere between 150 to 200 persons with HIV in their studies, but they did not report on that in any of their reports. The Janssen and Janssen included 18 persons with HIV in their study for a population of 2.8% of the participants, and just 6 of the persons got HIV. Two vaccine recipients and 4 placebo recipients. However, the numbers are too small to be relevant.
Thank you very much.
What they're saying is that it's not the whole virus that we use. And therefore, as long as there's no reason to suspect that there will be an allergic response, and as long as the person is not severely immunosuppressed, then there is no reason why with physician approval you can't have it.
Excellent. Thank you very much.
Last one has to do with
let's skip the last one. Can we go to Dr. Bailey? They asked you quickly about education and work. How are you able to actually measure the impact in terms of the economic fallout on that? I don't know if you have one quick sentence to say on that one. Dr. Bailey?
That question is addressed to me.
Yes.
It's obvious that the impact of COVID-19 has seriously affected schooling, and it also has affected the psychological status of children. And a recent study done in Jamaica has shown that a significant number of our children have fallen significantly behind in their cognitive abilities. So we really do need to get the vaccine rolling as quickly as possible so that school can be restarted, to improve upon the ability of our schools to deliver education at the level and at the capacity that is necessary to ensure that your children actually recover from what is now an essential slump in their intellectual capacities.
Excellent. Thank you very much. I'll hand over to Michael Kahane, our Bureau Chief, to give the final words.
Thank you, Dr. Harvey, and I want to thank this very distinguished panel for such an informative decision. I'm going to keep my comments extraordinarily brief because everything was so eloquently covered by this panel. For those of you who don't know, AHF, and we're very, very proud to be a sponsor of this program, but we operate in 45 countries and we have over 1.5 million patients in our direct care. And I think it's also important for me to note that we are also truly blessed to have Dr. Harvey oversee our operations in the Caribbean. I don't thank you enough for that, Dr. Harvey. So thank you for your service to the region. We started as an HIV organization, but we have expanded significantly beyond HIV into the realm of global public health. We routinely respond to regional health emergencies. We have expanded our operations into sexual wellness and sexual health. We respond to natural disasters throughout the world. We advocate for affordable housing because we all know that housing is directly tied to health outcomes. And important for this conversation, we have been advocating for a global public health convention. We started this advocacy before COVID and this pandemic, but it is all so relevant and has been, the importance of it has been driven home so significantly because of this pandemic. We must achieve a global public health convention so the world is ready for future public health challenges. Transborder agreements exist in all sorts of realms in the business world, whether it's banking or passport control or air traffic control, for example. They're all very well accepted. And part of the reason for that is because there are significant financial implications to those agreements being in place. As Dr. Bailey very well stated, not only are the public health considerations in not having a global public health convention so relevant, but the economic impact that this pandemic has caused, it has never been seen before. And I think it makes a very, very right time to move very strategically for the acceptance of global public health. The Americas and this region is already in a very unique position to rethink the public health order. This region has really taken a very unique and regional approach in its fight against HIV, which creates a great foundation. There's cooperation throughout the region between NGOs and government in fighting HIV. There are many cross-border agreements that are already in place because of the impact of migration in the region. We must make regional and global public health a priority. And we are convinced that the Americas can model such a convention for the world. So I hope that everyone watching this presentation will join us in that effort. I look forward to working with all of you and with all of these distinguished panel members in trying to make sure that we are prepared for future health emergencies by having a global public health convention in place. Thank you again to this distinguished panel and to IPAC for this very, very important discussion.
Excellent. Thank you very much, Mike. I think I want to just add thank you to the organizers. Thank you to my co-chair, Dr. Mark Edwards from the Joint Colleges of Oral Health, Dr. Anzinger, particularly for taking the time out. I know you're extremely busy at the university. Professor Christie, who is in extreme demand, and Dr. Bailey, who is a public figure in Jamaica, is on all radio stations. And I don't know what we would do without Professor Winston Davidson, who is a powerhouse at the University of Technology, School of Public Health and Health Technology, which I'm now associated with. So I want to thank you all very much, and really I'll hand back over to the organizers for any final comments. Thank you.
For joining. It was such a pleasure to have you all here with us today, and it was a really interesting session where you addressed the main issues we're facing in this COVID era. So thanks everyone for watching, and have a great afternoon. Thank you.
Thank you. Bye-bye.
Goodbye. Thank you everyone once again.